So again, this is really just talking about really why exercise is critical in the oncology population. Oops. So couple learning outcomes. Really just going to go over some statistics and why it's important right now. Some key definitions. If you did attend Shy's town hall, the definitions will be very much the same, but at least it'll be good to kind of rehear them and be able to apply them in this setting. Then we're going to talk about really the importance of physical exercise and physical activity at the molecular level. So if we want to talk about exercise, we kind of need to know why it's important, why dosing is important, kind of the effects that cancer and treatment has at the molecular level, and why they get weaker, why these individuals get deconditioned. And then we're going to quickly go through the FIT principles and some other stuff, and then really kind of get down into the nitty gritty of why a lot of our exercise prescriptions, not just saying in PT, but across the board, it falls short. We don't necessarily hit the mark. And maybe if we think about things that are brought up today and we kind of apply them, maybe our prescriptions get better and outcomes get a little bit better for our patients that we work with. So real quick graphic here. Basically what it's saying is that there's going to be way more cancer survivors in the coming years. And with that, that means we're probably going to experience more cancer survivors in our clinics, whether they're actively going through treatment, just finished treatment, or they're 3 years out, 5 years out, 10 years down the line. We can still have benefits for them. We really need to be aware if they are a person living with and beyond cancer. We need to ask the appropriate questions, and we also need to understand the potential side effects that they've gone through and what their body's gone through. So some other staggering statistics that are not great. Really only about a third of persons living with and beyond cancer are meeting those exercise recommendations. And this number drops off even more greatly for patients that are actively going through treatment. And the one thing too, that within the study that they use this number, they use persons that are recently placed on maintenance therapy too. So really what this is saying is that these individuals aren't very active. And even as they're going through treatment, the effects of cancer and the treatment are really causing a toll on their body, and that if they're not moving, they're not addressing the potential side effects that are occurring in the acute phase, subacute, or long-term phase. And what's even more staggering is all persons living with beyond cancer, there's 34% of them aren't doing anything at all. They're basically just sitting around watching TV, maybe getting up to go to the bathroom, maybe getting up to get some food, which is also really bad. We know the benefits of exercise are really critical and physical activity is really critical. So we need to figure out ways to try and help get these individuals moving, get them motivated to move. We'll go into that a little bit later on, and really be able to educate why moving is important. So looking at these numbers and understanding that there are a multitude of reasons why persons living with beyond cancer aren't exercising or not partaking in physical activity. Mainly the top 5, though, that have been brought up in research too. There's really a lack of understanding of what exercise is, what physical activity is, also what actually the benefits of exercise and physical activity are. And it's not just with patients and caregivers, but it's also the physicians. And it kind of ties into that fear component too with both patient and physicians and caregivers, because there's not a lot of understanding at times. Physicians are kind of uncertain whether an individual is appropriate to do PT or appropriate to be exercising, what level that they should be exercising at, what type of exercise they should be doing. And also the patients aren't. So sometimes you'll have that patient that was like really physically active. They're a marathon runner. They went to the gym 3 or 4 times a week, and then they got cancer. And they're like, well, I got cancer. I'm going through treatment. Is it safe to even go back, or is it safe to exercise? And then there you'll have those individuals who never exercise in their life, and they are feeling really bad, and they want to know what they can do to help themselves. So being able to understand what, educate not only the patient and the caregiver, but also being able to educate with the physicians and talk with the physicians and be like, hey, look, you have this patient here. They're talking about high levels of fatigue. They're saying that they're having trouble getting up out of a chair. We really need to get them on a program. This is what I'm thinking. Like, what are your thoughts? Because there is that component of fear with it, especially as they get advanced cancer, bone metastasis, neurological components too. And then also access, time, and financial challenges. How close is the rehab facility or gym to the cancer center? How close are PT facilities within the community or gyms within the community? Where are the qualified individuals, whether it's a physical therapist that's knowledgeable in cancer, exercise physiologist, personal trainer, the sorts. Also, time too kind of ties into access as well, because if they're going through radiation treatment 5 days a week, their time may be limited. Also, if they have a family or they're still trying to work, time will be limited. So how can we address these barriers too? And financial challenges as well is a big one. Healthcare in the United States is awful, it costs a ton of money. So how can we make our access more affordable? Or how can we find affordable resources for these individuals to be physically active as well? So real quick, 3 key definitions: ADLs, physical activity, and exercise. So ADLs don't really cut it when it comes to exercise and physical activity metrics in terms of whether they're meeting physical activity guidelines, even if the ADL is considered like a max movement for them, because it's not really long enough normally. And that's one thing we'll get into in a little bit. But the physical activity is more so, it could be really anything that's going to increase, it's going to work their muscles, might increase their heart rate a little bit, maybe increase their breathing. But there is a varying of it. And if you ever heard of metabolic equivalence, you can like type in metabolic equivalent chart, and it'll give you kind of like a rundown of what's considered low activity, moderate activity, and vigorous activity in terms of metabolic equivalence. And that's kind of a good way to talk to patients about, hey, like, this is what you're doing. This is kind of where we can classify your physical activity level, but like, hey, can we start doing more, or can we start working harder? And then exercise is a subset within physical activity, but it really has an intermediate or an end goal of improving physical fitness, whether that's your endurance, muscle strength, muscle power, muscle strength, balance, coordination, flexibility, something like that. That's really what's considered exercise. Both are vitally critically important, because most people, well, not most, but the majority of persons might not want to actually do formal exercise. They've never set foot in a gym before. They've never lifted weights. But if we can tie exercise to physical activity or to hobbies that they do that are considered physical activity, we might get better buy-in with that. And we might be able to actually get them on an exercise program where they're doing resistance training to help them, one, be physically active and meet activity guidelines, would help them get back to doing what they want to do, improve overall survival, and improve quality of life there. So now we're going to kind of dive in a little bit to why appropriate exercise is critical. If you've ever looked at any articles or you've worked with cancer patients, you know there's a whole host of effects of cancer in the related treatment. Fatigue, loss of muscle mass, bone loss, impaired functional capacity, VO2 max, CIPN, pain, you name it. One thing is, they normally don't come individually. They're normally in clusters. So that's one thing to consider a lot, is that a lot of this stuff is clustered. And exercise, depending on whether it's resistance training, mobility, yoga, walking, swimming, the likes, will address more than just one of these components, but sometimes one aspect of exercise or physical activity might be better suited to address these, depending on what it is and patient to patient. So this is kind of a little graphic that I made here. I'm going to call it like the cyclone of reduced quality of life, or like this downward cyclone of happiness, because fatigue is one of the most highest reported side effects or adverse effects of cancer and treatment. So if you look at the top, we get fatigued, we get tired, they don't want to move, they get weaker, they sit more, they don't move as much, they get stiff, and then they get worried that they're going to fall, so they sit around even more, and then their VO2 max drops off and they start to atrophy significantly, and then it all boils down to a really bad quality of life and debility and frailty and increased mortality and morbidity. So looking at this, if we can interject and provide services higher up the line when they just start to develop fatigue, or when they start to say, hey, I'm not moving as much, or I'm not as independent, we can really stop this downward spiral, or we can slow the downward spiral depending on where we see them at, and maybe hopefully stop it or reverse it a little bit too. So looking at some molecular effects of cancer and its related treatment. So these are like the 5 big ones I'm going to talk about here, but systemic inflammation, altered hormone levels, mitochondrial dysfunction, muscle atrophy, and vascular dysfunction. And these all, again, play a symbiotic role. So it's not one alone. It's more along the lines of everything's boiling, which one's affecting the most, and how in sequence are they affecting each other. So systemic inflammation is common. It's actually one of the characteristics of cancer is what they potentiate is systemic inflammation. And what it does is it kind of helps them evade our innate immune system. But what it also does is it leads to altered hormone levels. It leads to mitochondrial dysfunction. and muscle atrophy and vascular dysfunction. So with systemic inflammation, we're going to see upregulation of like C-reactive proteins, some interleukins, but that's also going to affect our hormone levels. So we're going to see increased free-floating estrogen potentially. We're going to see altered testosterone levels. We're going to see higher cortisol levels, which is going to affect myostatin, but it's also going to affect our mitochondria. So our mitochondria will not be able to regenerate. They're not going to be as efficient at producing energy, which means they're going to actually throw off more reactive oxidative species and reactive nitrogen species, which is then going to actually potentiate systemic inflammation. And that all boils down to us not utilizing oxygen for energy enough. We're having this energy imbalance and our muscles can't function, which also leads to vascular dysfunction too, and kind of goes forward and backwards. So really when we're looking at this, there's a lot going on with cancer and its treatment that's affecting us at a cellular level and a molecular level. And we need to consider these aspects of why we're doing exercise, why exercise needs to be at the appropriate level, and what type of exercise we're doing to maybe address certain aspects of where they're at in functional decline or what they're presenting with most deficits-wise. So this is a really nice graphic by Coellen. He's out of Australia. He's done a lot of research in the molecular effects of exercise. He's also done a lot with prostate cancer survivors. But on the left here, we're looking at sedentary individuals. So like I said, we're going to have increase in metabolic syndrome aspects. We're going to see increased insulin resistance, increase in blood glucose levels, increase in free-floating IGF-1, which cancer and tumor microenvironment utilize glucose, and they utilize IGF-1 to potentiate and grow. We're also going to see, like I said, increased sex steroids, so altered hormone levels, increased inflammation, and we're also going to see increased autonomic dysfunction. So I think one thing to point out, though, here is just an acute bout of exercise. So normally when we talk about exercise, we're like, oh, the individual needs to be fit to get benefits. However, that's not necessarily the case. There's some research being done in the cardiotoxicity realm or treatment tolerance realm of an acute bout of exercise before, during, or after chemotherapy infusions or administration to really see the benefits of doing exercise at an appropriate level then. And this is kind of going over that. So say this individual here, they're getting infused with chemo. We get them on a bike. We're having them exercise at moderate level. It doesn't have to be anything crazy. But they're going to see an increase in respiration, increase in cardiac output, increase in glucose output. They're going to mobilize, hopefully, some free fatty acids for energy. But what's really happening, and that can be potentially important, which we're doing a lot of research on now too, is we're going to see increased tumor perfusion. So when we exercise, the blood goes to our muscles because that's what's being utilized. So we're going to get vasoconstriction at our organs that aren't necessarily being utilized. However, tumor microenvironments that are solid, they have their own blood vessel network. They don't vasoconstrict, so they're going to stay vasodilated. So blood is going to potentially go to the tumor microenvironment as well. What that means is we're going to see an increase in oxygen delivery. We're going to see an increase in catecholamines, decreased hypoxia, which tumor microenvironments, they enjoy hypoxic states because it helps them potentiate. It helps them use the glycolytic process to grow and fuel themselves. We're also going to see increased shear stress, which shear stress they're looking at is pretty important. That's how it looks to look at breaking apart the singular cells within a tumor microenvironment to help our innate immune system, which does get upregulated with acute bouts of exercise and with prolonged bouts of exercise. So we're also hoping to hopefully mobilize our immune system that's there working and also push chemotherapy to the tumor microenvironment. And what happens more is if we can get these individuals to stay exercising routinely, be active, we're also going to see downstream effects on the tumor microenvironment as well, but we're also going to see benefits for their body. So we're going to see increased insulin sensitivity, which is going to help shuttle glucose into the muscles to utilize for energy. We're going to see reduced free-floating IGF-1. So because our muscles are being active, they're going to actually uptake the IGF-1 to try and help maintain and grow. We're going to see reduced free-floating sex steroids or hormones. Inflammation is going to hopefully go down, and the autonomic dysfunction is going to regulate as well too. So this is why exercise really matters on the molecular level, because we're going to see that improvement in vascular dynamics. So we're going to see adequate nitric oxide release. We're going to vasodilate. It's going to help hopefully be benefit to our cardiac muscles, increase capitalization to our muscles, hopefully maybe increase capitalization to the tumor microenvironment. Again, they're also looking at that a lot now too. We're going to see those anti-neoplastic effects, whether that's increasing our immune response or helping deliver the chemotherapy to the solid tumor microenvironment. We're going to see, like I said, regulation in hormone levels. So we're going to see a reduction in cortisol levels, hopefully. That helps reduce that systemic inflammation, helps muscle protein synthesis. We're also going to see mitochondrial biogenesis and muscle protein synthesis. So there are some things to be considered of, though, with muscle protein synthesis and mitochondrial biogenesis. They work at two different levels. So there's different aspects that help our body grow and respond to stress and stimuli. So really what they found is with promoting mitochondrial biogenesis, aspects like calcium shifts within the cells or within the body, alterations in our energy levels, whether it's going like when we use ATP, we end up with ADP. So whenever our body starts to see that shift in ATP and ADP when we're exercising, that'll kind of help potentiate that mitochondrial biogenesis downstream. Whereas with shear tension, damage to cells, cellular swelling from resistance training or maybe high intensity interval training, that will help with muscle protein synthesis as well too. So there are those different dynamics, and that's why it's important to consider what we're doing with an individual and why we're doing it with an individual. Because it's not like aerobic training will necessarily increase muscle size or get us stronger, but it will help us with our mitochondria as well too. And one thing to consider as well is that there are mitochondria that are within different layers of our muscles, so that we have subsarcolemmal mitochondria and we have interfibular mitochondria too. So with muscle atrophy, we also lose quantity and quality of our mitochondria. So if somebody's very frail, cachectic, they've had a lot of muscle atrophy, we also need to be considerate of that because they might not have enough stores or enough space to really help grow mitochondria at the same time too. And they're also looking into that now as they're starting to try and do assays about individuals that have had significant weight loss and looking at quality and quantity of mitochondria and trying to figure out, what's the best course of action for these individuals in terms of exercise or pharmacologic interventions. So in 2019, the American College of Sports Medicine, they got a roundtable together, some experts in the oncology field, and they really talked about exercise. And they found within research that there was some strong evidence that exercise helps with anxiety, fatigue, health-related quality of life, lymphedema, and physical function. If we look at it, that's probably a cluster in itself. They're anxious about getting lymphedema, or they have lymphedema and they're anxious. They might have fatigue from treatment. Health-related quality of life is probably reduced, unfortunately. Physical function is also reduced. And then they found moderate evidence in research for bone health and sleep. And at the time, there wasn't enough research to really make a certain statement on like cardiotoxicity or falls or pain or treatment tolerance. But what I will say, since this is published, there's been a lot of research done on cardiotoxicity in the breast cancer population, and they're finding some really positive benefits. Whether that's doing exercise during infusion or prior to infusion, or they're looking at high intensity interval training and cardiac biomarkers and stress biomarkers too. And found some pretty promising benefits of high intensity interval training, and as well as doing those like biking sessions during or prior to getting chemotherapy. So this is a quick little graph to think about and kind of put everything into perspective a little bit. So physical functions on our Y, age and chronologicals on our X. The main black line that kind of goes up and then drops off, that's just normal aging process. So physical function grows, peaks around the fourth decade and then slowly declines off. The blue dotted line is somebody that's been physically active through their life and is maintaining that physical activity and exercise. So they're not going to have as severe as a drop off. The black line, however, though, is like the onset of cancer, like it's labeled. So cancer occurs, they start to have fatigue, they're losing a lot of weight. They drop down into that realm where there could be significant debility and experience morbidity and mortality at a higher rate. And this is where we really can be important. We understand the effects of cancer and we understand the effects of treatment. The red dashed line is where we intervene. So cancer normally occurs before diagnosis sometimes. So we don't always get to intervene at the onset of cancer, but the sooner we intervene with services that are geared towards improving physical function and their deficits, we potentially help keep them out of that aspect of debility and mortality for a longer period of time, which potentially helps them tolerate treatment better. I'll talk about that a little bit later. But this is what's really critical, and this is kind of putting it into perspective that what we do is vital, and as long as what we do is very critical to their outcomes at times. So in that roundtable in 2019 through ACSM, they also did come out with some statements here too. So minimum recommendations they found that were beneficial for individuals living with and beyond cancer was 30 minutes of aerobic exercise 3 times per week, and then it's resistance training 2 times per week, focusing mainly on large muscles, 2 sets of 12 to 15 repetitions. But they also did say that individuals with cancer should attempt to be active every day for at least 3 times for 10 minutes, so 30 minutes a day. And this is kind of why also too, when we're talking about ADLs, physical activity and exercise, the minimum benefit that they're going to find, it needs to be for 10 minutes. So if they're getting up and just going to the bathroom and coming back, it's probably not taking them necessarily 10 minutes of activity. And why we need to really be able to educate, saying, hey, like, I understand like getting up and going to the bathroom is really tough for you, but we need to try and do more piecemeal, more in through the day to help you get more stores and get better endurance and more strength and balance and power mobility, because what you're doing isn't necessarily benefiting you in the long run. But even though with these minimum recommendations that they set out, they also did say that anybody living with and beyond cancer should really try and get the minimum of 150 minutes of moderate and or 75 minutes of vigorous exercise per week. And really what this means is exercise is critical, and because of that, it should be treated as a vital sign. And I know there's a number of organizations and health systems around the United States and some around the globe that are treating exercise as a vital sign, and they're really diving into what the individual is doing, what they're, how frequently they're doing it, when they started it, how long they've been doing it for. But we really need to try and get this as a vital sign within all health systems, because we need to be asking about what their activities were, what their previous activity levels were, and assessing and routinely checking it, much like prospective surveillance, like they do with the breast cancer population. So prospective surveillance, they go in, they take measurements routinely through as the person's moving through, and we could do this with exercise. So this is why we really need to be within multi-D clinics, trying to be within the community, doing community events, being within other like infusion clinics as well too. Because they're probably going to come in every 3 weeks. You can catch them every 2 cycles. So every 6 weeks, you could check in with them, maybe run them through a quick little screen, see how they're doing, talk to them about, hey, look, I know you're dealing with more fatigue. Can we try this? Can we, and I'll come back and see you in 3 weeks when you come back in for your next infusion. And we'll check in, see how you're doing, see what we need to rearrange, revamp, tailor to you. But really, we need to move forward with the exercise and our ideas of exercise so that we can start to track this maybe progressive loss of physical function and jump on it sooner, rather than them, crawling into us in a wheelchair and barely being able to get out of a chair when they're seeing us, and hopefully reducing admissions, reducing other costs like falls and ED visits and urgent care visits and the nature that way. So I'm going to kind of breeze through foundations of exercise programming. Really should be multimodal. You might be focusing on one thing more so than the other when they initially come in, but really when it comes down to it, you need to kind of get them going on every single aspect to some sort. And then principles of exercise program: frequency, intensity, type, time. You're going to hear those all the time. But also there's the specificity of a program, volume, and then progressive loading. If you have background in exercise science or with the FIT principles of exercise programming, normally it would be progressive overloading, but I am going to challenge that a little bit here later on about why progressive overloading might not necessarily be the best course of action for this population. Aerobic training, really, the only thing I want to comment on here is intensity. So 40 to 90% of VO2 max or heart rate reserve. I will tell you, I personally do not use VO2 max or heart rate reserve that often when I am dosing aerobic training, just because most of my patients that I work with, I can't test VO2 max safely, and most of my patients are on beta blockers. So that's going to blunt our physiologic response to exercise. So that won't give me accurate reading. But there is, like I said before, METs you can use. Some machines will actually track METs, so you can use that and you can educate your patient on, hey, when you go to the gym, I want you to try and maintain this MET count for this many minutes. Also, what I will use though all the time is RPE. And I use the 0 to 10 scale. I don't use the 6 to 20 scale. The 6 to 20 scale trips up a lot of my patients sometimes. So 4 to 6 out of 10 is that mod. Vigorous is that 7 to 9 out of 10. And really, you can have them do anything as long as it's the right intensity for the appropriate duration. Resistance training. So frequency, 2 to 3 times per week on non-consecutive days. I actually would argue that it should probably be maybe 3 to 4, 3 to 5, depending on the individual, and if we know the benefits of exercise. Volume. So normally when we think of volume, it's sets and reps, but volume, we really need to consider sets, reps, and resistance. So we can vary these three variables in here. Terrible way to define that. To really get the right appropriate volume and vary things on day span. I guess I'll use vary. In literature though, 60 to 70% of the 1RM is probably considered baseline for improving strength, but that doesn't really hold true if we're looking at untrained individuals or even trained individuals to an extent, because we can really go as low as 30% of the 1 repetition max. And really, as long as the volume is appropriate, we're still going to see benefits. So resistance might be 30% of 1RM, but that just means we're going to do some more sets and more reps. The bolded and underlined 10 to 20 sets per week per muscle, that's really looking at hypertrophy. Hypertrophy in the oncology population is very difficult, what research has shown. Mainly, it's multifactorial. It's not just because they can't grow muscles, but it's based on nutrition and volume and consistency with exercise programming and timing of exercise programming. But if we're trying to really, appropriately hit volume, maybe we're not going for hypertrophy, but we should maybe trying to be hitting 10 to 20 sets per muscle per week to really help promote that. So it doesn't mean you're going to just go and hit like 20 sets of bench press, or have them, if you're having them do bench press or like cable flies, because you can do wall push-ups, you can do cable flies, you can do floor presses or stuff like that, and that still counts. That's still also getting deltoids, it's still getting your arms in there. So I know it can sound a lot to get in, but really think about it. It's not just one muscle. It's not 10 to 20 sets per muscle, per movement or per muscle that way, but you're getting everything going on multiple movements, especially when they're multi-joint. So real quick, Rpe scale, the 6 to 20, the 0 to 10, and then the perceived effort. I know green here is, the 3 is in greens. Mine will sometimes, I'll use this one when the patient's extremely deconditioned, just because the 3 might actually truly be something that's maximum effort for them. They just can't equate because they can't get to a higher effort to really be able to judge. So sometimes when they're really deconditioned, I'm fine with them being at a 3 out of 10, but I'm going to try and quickly progress them so that they can tolerate 4 to 6 out of 10 effort that way. And then another one that's used a lot in strength and conditioning is reps in reserve. So again, green kind of means go. So 6 to 8 out of 10 is really beneficial. And I use this a lot for resistance training. It really helps to auto-regulate based on day-to-day and how they're feeling. So when we're designing that exercise program, we really need to assess the individual and take in everything that they can give us. So medical background is critical. So primary diagnosis, comorbidities, whether it's cardiovascular disease, COPD, type 2 diabetes, because sometimes a comorbidity might be, they might be more concerned with the comorbidity or symptom from their comorbidity rather than their primary diagnosis. Also lab values, not going to necessarily get into that today, but we need to be aware of their hemoglobin, platelet counts, white blood cell counts, just based on setting and what we're going to use. Also cognition, because we need to make sure that they're safe and understanding of what we're going to be doing and being able to process what we're asking of them, but also whether or not they can carry out an HEP at home. And then nutrition. So again, not really going to dive into nutrition here, but we really need to understand what their appetite's like, how many meals they're eating, roughly how many calories they're getting, and what their protein intake's like. But also, bigger things that we need to consider also are like perceptions and beliefs of exercise, because not everybody, like I said before, has ever stepped foot in a gym or ever wants to step foot in a gym or exercise. So we need to understand like whether or not they're willing to do exercises with us in the gym and do stuff at home. When they're done with us, are they going to carry on with this stuff? Would they prefer to carry on at home, or would they be interested in maybe joining a gym, or would they maybe be interested in rounding back and talking about it later on as we move through the plan of care? What their goals and main concerns are. So if we can apply what we're going to be doing with them in session, we're going to hopefully be able to get that buy-in and get them to engage in that exercise and physical activity with us at an appropriate level, and then continue on that at home. And then big things, we need to make sure that they can move. We need to get baseline physical function. And then once we get it, we all synthesize this, figure out a good path for them to take with us. And then we continually reassess to make sure that we're doing the right things, that they're getting stronger, that their balance is improving, that their mobility is improving as well. And if it's not, we need to figure out why it's not. And if it is, we need to keep going down that path and maybe changing up and fine tuning it just to make sure we can keep continuing to get those gains and we don't plateau. So performance potential, I think this is, if we think about performance potential, we're going to think about athletes, how are they going to perform on game day, but it's also critical within this population too, because a lot of times these individuals are going through a lot. Fatigue, sleep, soreness, pain, anxiety. They're taking care of their kids. Their dad's sick and they're running back and forth to the hospital, or their kid's sick and they had to stay home with them. So their performance is not going to be the same session to session. You can run the same session 5 days a week. They're going to perform it. They're going to rate exercises on RPE and RIR totally differently. They're going to recover totally differently from each one. And this is why we really need to be asking them at the start of the session how they're feeling, how they felt after the last session, what they did they do their exercises, how sore are they, and be checking lab values when they're available to us and really asking about how well they slept and what their fatigue's like that day. Because we need to be able to tailor and tweak on the fly to really help make sure. And that's why we should be using RPE and RIR for almost every single exercise so that we're not overdosing, but we're not underdosing within our sessions. And this is a nice little graphic looking about how we're going to undulate our exercise programs week to week, but also why really inquiring about performance potential and thinking about their performance potential is really critical. So this is a nice graphic from Dr. Kirkham, who's done a lot with chemotherapy, exercise, and cardiotoxicity and exercising. So cycle 1, cycle 2, cycle 3, cycle 4, if we think of the symptom such as fatigue, it's going to probably get worse over cumulative cycles. And then on the right here, we're looking at the intensity of an exercise program on the y-axis as well as duration, and then cycles and weeks going across on the x. So if we see it, they're going to gradually build up that intensity and duration of the program, and then as soon as they hit cycle 2, they're going to drop the intensity off, duration is going to stay high, and then they're going to build back intensity while they're reducing the duration. The one thing I do want you guys to note though is if we look at weeks 5, 8, and 11, the intensity is growing across those weeks. So it's not that the second week is always at the same intensity, but the second week is always growing in intensity as well too. And if you look at 6, 9, and 12, we're building progression in intensity. It's not like we're dropping the intensity off and we're rebuilding the blocks all over again. We're dropping off, but we're starting and growing at a faster rate so that we reach a higher level by the time we're at week 12. And another thing that I think a lot of our patients don't consider or don't understand is the difference between pain and soreness. I think a lot of times physicians don't understand the difference between pain and soreness too. So soreness is, in my opinion, is acceptable. I tell my patients, it's all right to be sore as long as you're not crawling out of here, or you're not stuck in bed the next day when you're done with me, or you're not stuck in bed from your HEP. And that's really more like that dull, tight, and achy feeling, and definitely they're going to feel burning when they're exercising. But mobility, movement, moving around, rest, recovery will help. I normally will say, if you're sore when you wake up in the morning, get up, move around, do your HEP in the middle of the day, see how you feel. Pain, on the other hand, is a little different. Pain doesn't mean it's bad to move. It means we might just have to figure out a different way to move. And that's more through that targeted exercise. Maybe we're modifying. Maybe we do need to rest. Maybe we need to focus on mobility within the joints too. And that normally will come on within the first couple reps and linger, or it'll come on in the first couple of reps and it might dissipate. Well, like I said, if they do have pain or they're really sore, we shouldn't be throwing exercises out the door. We need to modify. This is critical because, like I said before, there is that component of fear within the patients and caregivers and physicians. So we don't want to say, oh, you're having pain with squats, we're not going to ever do squats again, you shouldn't ever again. Or, oh, we're never told to flex your back, extend, rotate, side bend. You can't ever do that again. That's probably actually going to set this individual up for more injuries down the line, whether that's from a fall or they're trying to pick something up from the floor like a goofball and they end up hurting their back or their knee or their ankle or something like that. So we really need to be saying, hey, look, I know you have bone metastasis. I know you don't really have pain right now, or I know you had a kyphoplasty from a vertebral fracture, but like we can progress. We can modify the range of motion you're moving through. So we'll start small, build big as your body tolerates. We're not going to use any load to start, but maybe as we get you moving through greater ranges of motion, we'll try and add some type of load so that you can really feel your abdomen and your ab muscles and your core muscles working, and also start to learn how to squat appropriately using your glutes and your quads and your hamstrings. And then maybe we're going to start small. We're going to really work on moving carefully through the movements. So we're going to go to slow tempo. And then maybe we're going to, as you get comfortable, we're going to load you lightly or not using a load, but we're going to have you move faster through that movement. So you get comfortable moving faster. And then we're going to, but maybe we're, like I said before, we're going to break the movement into parts, or we're going to focus on concentric and eccentric depending on what is going on. And really what this does is it helps promote movement. Movement resistance training that all has that analgesic effect on it. So people will walk in and they won't be moving around and they'll be really rigid and they'll be in a lot of pain. And it's probably, pain's multifactorial, but one factor that's probably attributing to their pain is that they're not moving. They're trying to hold themselves in guard. So if we can encourage movement and incorporate it slowly to their level, we're hopefully going to get that analgesic response. But we're also reducing that kinesiophobic response and that fear of movement. There's a huge debate right now on Twitter in the orthopedic world between spinal flexion and whether it's good or bad for you when you're deadlifting. And, that's like one aspect of not enough people in the world move right now, enough as it is. So why are we telling people not to move if it's not hurting them? In this population, that's a little different. So maybe we do need to clear them and make sure that they're moving safely and that they're not going to potentially do any more damage. But if they're not doing any damage and they're not going to hurt themselves, like we need to let them move. We need to get them safe and stronger when they are moving too. And resistance training really has that strong component here because it does potentially help reduce pain. It also helps build their foundation and strengthen their foundation to move through. So kind of getting into where exercise programs fall short now. So there's 3 ones that I'm going to talk about. So specificity of a program, volume of a program, and then progressive loading to adaptation. So that's the caveat there where we're not doing progressive overloading anymore, but we're progressive loading to adaptation. So specificity. They're weak, we got to get them stronger. Walking program is not going to cut it. Volume. That needs to be sufficient. And really what research has shown is volume is not sufficient in a lot of programs in research, but also in the clinical setting as well too. So we need to use that. If we are using percent of max, we can use it. RPE and RIR is really good too. I personally will test what their like 5 RM or 8 RM is. And I'll use that as a tracking point. I won't necessarily base my resistance training off of that because again, the performance might vary day to day. But I'll say like, okay, cool. This is where we're starting. We're going to check in 4 weeks from now. Let's see where you're at. Hopefully you're higher on your 5 RMs. If not, then we weren't dosing appropriately. I wasn't doing a diligent enough job to progress the load as you tolerated it. Or there's a disconnect between RPE, RIR, and what you're reporting to me and what you're understanding of those as well too. Total time under tension does matter as well. There's a little nuance with that though too, depending on what we're trying to promote, whether that's strength or power. Obviously with power, there's gonna be less time under tension, but there are ways we can finagle greater time under tension with that. And then progressive loading. If we want to get positive adaptations, we need to continuously stack the blocks. And as we stack the blocks, we're probably going to get progressive positive adaptations. So it is really moving away from progressive overloading where we're using that percent of max or we're using that heart rate to increase the percentage of and the intensity of an exercise program day to day, week to week. Because again, performance potential varies day to day, week to week, month to month, especially when they're going through treatment. And we don't necessarily want to overexhaust them because there are downside effects of that too. So specificity, this is where I'm going to say reps are probably better than steps in this population, and I will fight anybody who tells me otherwise, or at least have an educated talk with them, and we'll express viewpoints that way. Because really, this population is stupid weak. They're really honestly they get weaker before we even know it, and if they have muscle atrophy and weight loss, they're probably really weak. And they've probably already lost a significant amount of weight because that weight loss isn't just fat loss. It's probably mainly muscle loss. So when you see that really tiny individual that walks in that said they lost 40 pounds before they even started treatment, and they lost another 25 pounds as they went through treatment, and now they looks like they barely have any meat on them. They're really weak, and they probably could be classified as frail. Fortunately, individuals that are frail, individuals that have had significant atrophy and muscle weakness, resistance training works for them in research, in the oncology population and in the older adult, elderly, frail population as well too. The problem is that type 2A, type 2X, which is our fast twitch, fatigable, fast twitch, fatigue resistant, normally atrophies first. And this is not just in the, say in a disease state, but as we get older, our type 2A, type 2X fibers atrophy first. We keep our type 1s because those are more of our postural stability muscles. So if they weren't active in the beginning, they probably didn't have a lot of type 2A, type 2X. And if they're, gone through treatment, they probably don't have much left. So this is why, resistance training is really critical. And if they are really weak, can they even walk at an appropriate distance or an appropriate speed to even get benefit from an aerobic walking program? So that's the one thing, you'll normally hear is like, they'll say, oh, I was told I just need to walk while I'm going through treatment. But if they can barely walk into the session, or they're saying, oh, I can barely walk, a block or 3 minutes, and then you're really like, well, did that walking really benefit you? Did somebody telling you to do a walking program really benefit you? Getting somebody to do resistance training, getting somebody to do body weight exercises, like sit to stands, lunges, marches, that can be tough, but we really need to be, stand behind it and be really understanding of where people are coming from, but also we need to educate them on why these exercises are critical. And sometimes that's really tough. But if you can say, hey, look, I know you're telling me that, again, you're having trouble getting up, you're having trouble walking. Let's try this, crazy resistance training out for a couple of weeks. Let me know where you're at. I'd be surprised if you say you're as tired even too. The one thing I will say though is high intensity interval training is being used a lot and researched a lot in the oncology population. They normally will look at cardiorespiratory fitness, but I really wish that these studies would also look at muscular strength, because high intensity interval training is not necessarily aerobic training either, just aerobic training, because you're probably getting enough stimulation within the motor units that you're getting recruitment, and you're also probably putting them through enough resistance at times, depending on the machine you're using, and intensity, that you're also getting muscular changes, whether that's neuromuscular or you're getting physiological adaptations. So that I really think we should start looking at muscular strength and endurance and power in these studies as well too, when we're utilizing high intensity interval training. And two, it is critical, because if you look at research as well too, mortality and overall survival are well correlated to muscle strength and muscle mass. And this helps improve outcomes. And this is why they're starting to look at individuals that have higher lean muscle body tissue before they start treatment, and looking at them when they end treatment and seeing what toxicities occur, how severe their toxicities were, and what their quality of life is. Because they're starting to see correlations between better tolerance to treatment with increased lean body muscle mass. And that's what we're trying to move towards now, is how do we prehab these individuals, or how do we work with them as they're moving through treatment to really improve and maintain what they have, so that we hopefully reduce these adverse effects. And then volume is, again, really critical. We don't want to just randomly pick resistances. We really want to try and dose it appropriately. But again, heavy resistance isn't the end all be all for promoting strength and hypertrophy. So you're a gym bro, or like, oh, I got to go lift heavy weights. It's not necessarily the case. Higher loads are going to get us better strength gains, but hypertrophy might not be on the back end the best, because the volume might not be appropriate. Lighter loads though, we might get that strength gain, we might get those hypertrophic adaptations, because we're going to get to that volume where they're maybe getting that cellular swelling, they're getting enough shear stress, or we're going to get that muscle protein synthesis. And load management is really intricately intertwined with overall sets and repetitions. So we need to get the motor units sufficiently stimulated, so that we can build upon that and we get those neuromuscular adaptations. And it really doesn't matter where the resistance is at. It's just, we need to make sure that everything matches up so that it's volume equated. And this is a graphic kind of showing that. So, theoretical hypertrophy zone is the red dark dash line running perpendicular to the x-axis, and then perpendicular to the y-axis is our strength zone, hypothetical. But high load, low volume, normally what we'll see, they're going to definitely get their strength gains, but because that volume's so low, we might not see as maximized hypertrophy. That's not necessarily to say that we won't see any hypertrophy. It's just it might not be as maximized as if we were using like mod load, mod volume, or low load, high volume. The one thing though that I will say we need to stay away from, which I think it's been shown in research and you can see in the clinic all too well, is low load, low volume, because that's not going to do jack squat for us in our patients. Progressive loading though, so not necessarily progressively overloading, but we're progressively loading them, and there's an infinite number of ways to do it, whether that's rest, sets, reps, different routines, different sequences. But as we need to keep it fun and entertaining. We need to vary it just for the sake of the patient. But we can't just be throwing like Monday session can't be 10 random exercises, and then Wednesday session can't be another 10 random exercises, and then like the next week Monday's another 10 random exercises. Because you're going to get neuromuscular adaptations, but you're not necessarily going to allow them to progressively load themselves and get those positive adaptations where we're really stimulating all the motor units, really helping to drive motor unit innervation, right sequencing, firing, and then helping to stimulate muscle strength and muscle hypertrophy that way. So, PT is not necessarily the strength and conditioning world where we're just doing strength bench and deadlift Monday, Wednesday, Friday, and maybe doing some accessory stuff on Tuesday and Thursdays. So we need to get creative as well too. So, we can go lying to sitting to standing, work in one plane, go multi-dimensional, go from stable surfaces to foam, keep eyes open, eyes closed. Can you do bilateral row to single lateral rows? And then we can also get multitasking involved for like our balance stuff as well. And also, talked about this kind of with that undulating aspect of exercise. We need to think about exercise periodization because it does depend on where they're at in treatment and what they're going through. And if we can get them for prehab, if we can get them for in treatment, we can get them for a post-treatment and into survivorship. It also depends on what they're coming in for too. So linear doesn't necessarily work like it would in the athletic world. Ours is more undulating. And we can think about it kind of like in that like strength, deload, maintain, strength, hypertrophy aspect where we're maybe, we get them for prehab. We're going to try and get them as strong as possible. We're going to see them we're not going to see them for that first week when they're starting treatment or two. So they're going to be doing their HCP. So it might be like a little deload. And then we're going to try and maintain as much as we can as they're going through treatment. And then once they get done with treatment, we're going to try and get them as strong as we can. And then after as we're starting to see that strength gains again, we're going to try and build their muscles as best as we can. But also we can think of it as like the stabilize, restore, strengthen, or like balance, because that's the biggest deficit. Get them stronger, then as the balance gets better, and then move it into a multimodal and then maintenance program that way. So there are a number of ways that we can build programs and design programs in terms of routines. I'm only going to highlight a couple of them. I do have some patient videos that we'll kind of like click through intermittently here to show you kind of like how they go in session. The ones I'm going to highlight though are Metcon, circuit training, interval training, and then cluster sets and high-speed resistance training. So Metcon. So if you're in CrossFit or ever done CrossFit or heard of CrossFit, couplets, 2 movements, triplets, 3 movements, can be done for time or have a time limit, but it does normally have a predetermined volume prior to starting the movements. And normally my instructions are, hey, this is your couplet for the start of the session. You're going to do probably 2 or 3 couplets today. You can rest as much as you want during the couplet, but once you're done with the couplet, I'll probably give you like 5 minutes rest. We'll do some mobility. Maybe we'll do some like walking and recovery. And then we'll maybe do some balance stuff, depending on how you're feeling. But I really want you to push the intensity. I want you to try and get through it as fast as you can, because I am timing you. And then on the right here, just a couple examples that I've used recently with some patients, 40, 30, 20, 10, where they're just ping-ponging back between step up and overs, and wall push-ups, or the triplet where they did 3 rounds of 25 squats, 10 modified burpees, and 12 TRX rows. So give me 1 second here. So we're going to go to, sorry, I'm going to click. Okay, so this is one patient here. Her background is, she has ovarian cancer. Sorry, I'm trying to get this so I can like that away. She had stage 3 ovarian cancer. She had just gotten done with treatment, her main treatment. Now she's on maintenance therapy with Avastin. Unfortunately, when we were going through our plan of care, she developed DVT in her left upper leg. Was not inhibitory. Her medical oncologist said, just keep doing what you're doing. It was unfortunate that she developed one. So we just kept doing what we were doing. She responded really well to exercise though. And this is one of our little like couplet metcons where we're going from TRX rows to mod burpees. So what you can see is her form's not the best, but when it comes down to it, I really don't care about form as long as it's safe, because I just want her to move. And I want her to try and move with a purpose. So again, not trying to be fear avoidant, not trying to get nitpicky with form. Just if they're doing it and they're feeling the right muscles and it looks pretty decent, let it go. In my opinion. Again, we can talk if you don't agree. But she's done with the TRX rows, or she thinks she is, or no, I'm telling her to control actually a little bit more, but she's getting tired. Again, they can rest as much as they want when they're going through the movement. And then when she finishes, I'm gonna skip through here. She's getting tired. There was like 40 TRX rows. She did them all in a row. Now she's like gassed. And now she forgot what the mod burpees were. So she's trying to like psych herself up. But then I had her go and do 30 mod burpees. So for her, she did them pretty well. But she was actually able to jump back. She walked back for these and then she jumped forward and then up. So again, if we're thinking bone health, if we're thinking power, this is a really good movement if we can get them to do it, because they're getting that impact within their feet. They're also having to try and be explosive back and then forward, but we're also getting core, we're also getting upper body, we're getting that aerobic aspect in that too. And then she's just going through it, and my filming sucks because I'm not a good photographer. But what I'm gonna do now is we're gonna get into this later in a little bit, but cluster sets for the leg press. So cluster sets is a little varied because of it's not traditional sets. So traditional sets is thinking we're going to do sets. We're going to do 3 sets of 10. You're going to do all 10 sets in a row. After that 10th rep, or after that 10th rep, you're going to get like 2 minutes rest. Cluster sets is a little different, where we can do rest after maybe like every 3 or 4 reps. That's short, so maybe like 15 to 25 seconds. Have them do another 3, give them that 15 to 25 seconds again. Another 3 reps, 15 to 25 seconds rest, another 3 reps. And then after they get through that like 4th set or whatever, however many reps we're working towards, we'll give them that 2-minute rest. There's other ways where we can do rest after every single rep. That's pretty short, like 5 to 10 seconds. Or we can tell them, hey, I want you to do like 40 reps at this weight. You're gonna, whenever you get tired and you need to rest, you're gonna just rest like 45 seconds, and then you're gonna carry on. And then if you fail again and you need to rest, you're just going to get 45 seconds rest until you get to like that 40th rep. Here, we're kind of doing the intra-set rest, where she's going to rest about 15 seconds after her smaller sets. I think for her it was 3. But really what this is nice is it helps reduce fatigue, but it helps us build volume with higher weights. So in these situations, I'll normally put a higher resistance on, because they're doing those 3 reps and they're getting that short little break to kind of help keep them from fatiguing out before. So a lot of times what I'll say here is, yeah, there's no way if I did 12 reps in a row, I would have been able to do this weight, but they were able to do 4 sets of 3. And again, what we're doing is we're combining this a little bit with high speed resistance training. So I'm telling her, I want you to explosively push out as fast as you can with control. And then I want you to come back in a little bit slower with control. So here you can see she's resting, talking to her about it, checking in RER and RPE, saying, you know what, no, we're good. Our RPE is right now about 5. So I'm happy with it because we had another 2 sets on the back end, 2 full sets on the back end of this. Again, she's getting pretty good explosive power. She's coming up under her toes a little bit. Good form. So this isn't the kind of that example of the cluster set aspect here. And then what we're going to just do is we're going to go to, so background for this patient here. So again, she has metastatic ovarian cancer, high grade. She's gone through 6 lines of treatment when I was working with her. She was on maintenance Avastin again. She also had significant ascites where she had to get drained to the point where she had to get drained every week. So she got drained on Thursdays. I would see her on Mondays. No, I'd see her on Tuesdays and Fridays. So I'd see her kind of like couple days after she got drained, and then I would see her the day after she got drained. Normally, she would get like 3 liters taken off, and I think when I took this video, she was on her like 114th paracentesis. So she gets drained a lot, unfortunately, but she's still able to participate pretty well. This day was just after she got Avastin, so we took it a little bit easier. So elevated bridges to try and help incorporate, glute activation here, but also get the body moving, and then pairing it with. So I just told her to like crank away on the reps. This one was 50 bridges per set, and then she would do single arm like presses so didn't understand my directions, and then she would go. So that's 15 pounds in her hand there. And I think I had her doing sets of 10 on each arm. So she would do 10, 10, and then we would just go right back into the bridges. There'd be no rest. So clicking through, and then we'd get her set back up, and then she would just keep going. And she did that for 4 rounds. So that was one of the lighter days, but she wasn't feeling well, and her performance potential was a little bit lower. But we still had a session that was productive, where she felt like she was getting an exercise in and getting stronger and moving. And then this is my last gentleman here, who I worked for a while with. He had metastatic bladder cancer. One thing to note is he had 2 stomas. So he had a urostomy and a colostomy bag. But he did really well. He did have a couple of short admissions here and there as we were working for unrelated reasons. And he was also on maintenance therapy with Tecentriq. So here we're working. He was somebody at first that was like not all about resistance training, but by the end of it, which this was, he was all about it. Like he wanted to come in and was like, yo, I want to lift as much weight as I can. I want to do as much as I can. So sometimes we had to really dial it back because he really was like gung-ho by the end of it, but he did really well. So another mech on here of him doing rows, and then going into wall push-ups. So again, this is one where I said, look, you have the powers in your hands. You do as many reps as you want before you need a rest. He just kept going. He did this one unbroken. It was 40, 30, 20, 10 of rows and wall push-ups. And what I will say is when we started the rows, I started him at an RPE 4 for 15 reps. So I knew it would gradually get tougher. I was hoping that he would have to break. That's actually was the main point of why we started at RPE 4, because I knew it would grow, and I was like, I don't want him to go unbroken, but he did still. And then after that, we rested those 5 minutes and we got into Metcon B. So Metcon B was squats. So squats is to his capability. Again, it's not the prettiest form, but it's functional for him. And then we did like straight arm cable pull downs. So trying to almost replicate, in a sense, like Fran, if you've ever heard of it, which is 21-15-9 of thrusters and pull-ups, in a sense. So he went through this, again, unbroken. He was a little bit slower than I expected, but he did push himself on that first Metcon 2. So that actually kind of like went through, and I'm going to kind of just skip through a lot of these things here, but looking at the examples with circuit training, putting them in there, kind of using that resistance training aspect, resistance training aspect with some endurance as well, and some body weight stuff too. And then interval training, which we don't have in there, but I like to use this a lot. Again, I will look at heart rate response just to make sure that they're not dropping off the table. But I use RPE for it just because a lot of my patients are on medications where they're severely deconditioned and they're not necessarily going to have an appropriate physiologic response to it. And you can really vary the work to rest ratio as much as you want. So Tabata also is one that I use a lot for like new stepper, the bikes. It's 8 rounds, 20 seconds of work, 10 seconds of rest. When I tell my patients that doesn't seem a lot because it's only 4 minutes, but by the time they're done, they're like, yeah, I probably shouldn't have agreed to that. And then another one that I've used recently with a patient is 6 rounds, 30 seconds of work, 30 seconds of rest. So they would go through this, and then after each full round, they would get 2 minutes of rest just to chill, kind of catch the breath. And then this is a graphic of the cluster sets. So the intra-set rest is after that, those every couple reps, and then intra-repetition rest is after every rep, and then that rest pause is where once they fail, they just get that predetermined rest, and then they go back to continuing on until they get to the final rep. And then this is what I was talking about too: power training, high-speed resistance training. They've used this a lot in the frail older adult population here. This does have, if we're looking at what atrophies, this has really good reproducibility and benefits for this population, because it's going to target that type 2A, type 2X fibers as we have them moving faster through that movement. And it really does move away from that don't go too fast, fast is not better philosophy that we hear a lot too, maybe in clinic, where we're really trying to have them like be explosive up and then control down as well too. Loads are usually lower, but you can load them up depending on how many reps you're having them do in sequence. So really to wrap up here, we want exercise to be medicine, then we better dose it at the right volume and the correct dose, because I don't think medical oncologists really want to ever dose limit, or they're definitely going to give that patient as much chemotherapy at the appropriate dose for as long as they can, just like radiation therapy. But again, if they're getting something, that's better than nothing. So starting small and building big is kind of something that I normally will talk with my patients about, is like, hey, you haven't been moving really much at all. So let's, gradually build up, but I really want you to, be, by the time we're done, I want you to be moving at the right, amount. Exercise programs don't have to be fancy. So, they don't have to always incorporate that, like, squats on a Bosu ball while they're counting off, things that are orange in their head, or throwing a ball back and forth. If you really came into my sessions, it's really boring. It looks like it's something you would probably do in the gym, or like looks like a bro sesh, or we're just lifting weights and moving about and doing some stretching here and there and doing some balance exercises here and there. But my patients enjoy it. So I think sometimes when we keep it simple and we kind of, like I said, we don't vary the exercises too much, but we kind of have our focal pillar exercises that we're kind of using each session or each week to kind of check in and make sure we're making progress. It helps a lot that way too, because then we can really see them get stronger. You can say, oh, hey, 2 weeks ago you were only doing 115, but now this week you're already up to 165 even for a greater sets and rep scheme. And they're like, oh wow, I didn't realize. I was like, yeah. So how does that feel? Like, oh, it feels really good. And again, consistency is really big within this population. So not overdoing it and not underdoing it, trying to find that right medium. It's like that bell curve aspect. And really why we need to use RP and RIR and consider performance potential. And again, really moving forward, we need to find out, we got to get people moving. We got to find ways that we can integrate and get to more patients and really get them moving and set up clinics, whether they're small clinics, or set up bikes in infusion centers or radiation oncology clinics, work within the community with the local YFCA programs, or even local cancer survivorship groups and stuff like that, to really help provide education materials, help answer patient questions, and hopefully reduce fear about moving and exercising. I really do think that prospective surveillance model with exercise would work. It's just, it would take tailoring and time, but I do think it would be very beneficial for this population as we continue to learn more about exercise and the benefits of exercise within this population. So that's really all I have today. If anybody has questions, I'm more than welcome to answering them as best as I can.
Thank you so much, Andrew. That was fantastic. I can't believe I feel like you didn't breathe during that whole time. It was jam-packed. But I am already thinking about my treatment sessions for tomorrow and need to revamp after this presentation. So thank you so much. I have a question to get us started. I was looking at those videos and I was curious how you structure your home exercise programs for your patients, if you're still using the same structure of the Metcon, or if that's really just when they're in person with you, if you're using more of a traditional interval at home.
No, so yeah, that's a good question. I think it's patient dependent and person dependent. The woman that was doing the burpees, she actually ended up joining a Planet Fitness again. So her home program was a lot of mobility stuff because she was going, So like Planet Fitness like 3 times a week. So we said like, look, here's like the things you can do at the gym. And we kind of like were working towards that, but she was still doing like the mod burpees at the gym, just off a Smith machine. She like anchor it and do them there. And she was kind of rolling through that stuff. My gentleman that was at the last video, he also joined the gym again. His home exercise program was more mobility exercises, so like more body weight as well. But I did have him doing Metcons as well too. Really what I do though is I have a handout. So long story short to get to the answers, I have a handout about how to integrate into the gym and how to continue on with progressing your exercise program. And we'll go over that normally on the last like 2 or 3 sessions. And then I'll give that to them. And I'll give it to them on the second to last session. And be like, look, I want you to read this over. And if you got questions, come back in and ask me. And it's like, this is what you should do. I give them an Rpe and RIR scale too. It's like front and back. So that I'm like, hey, look, use this if you want. I know you understand it. But yeah, like I kind of try and make it as easy as possible for them to continue to get going that way. And I just realized I'm like, there we go, cool. So like understand how to continue to progress. And I'm always like, my door's always open. If you got questions, just call me or shoot me an email too. But it really varies on the person and what they like and what we need to do.
Got it. No, that makes sense. Thank you. Feel free to ask questions by unmuting or also in the chat. I'm happy to read them out. And Rachel, yes, we will be sending out a copy of this presentation. It will be posted on the APTA Oncology SNP website once the recording is finalized as well.
Yo, Liz, you got questions?
Actually, I do have a question that is a little off the wall, but related. I was talking with a colleague who has been encountering patients who have autonomic dysfunction after specifically adriamycin chemotherapy. And what she is finding is that they are having difficulty because they're trying to obviously get into exercise. And this one patient in particular really seems to be having difficulty transitioning into like running, walking activities because like those ground reaction forces are very challenging. And so I was wondering if you have encountered this first of all, and then I'll ask a follow-up question maybe after that.
So like when you say that they're having difficulty with like the ground reaction, is it like that they're having keeping themselves up or keeping themselves like stable or like feeling like they're in like a lot of like what do they do you know specifically?
I think it's heart rate goes up.
Okay.
And the patient can tolerate the elliptical at the same levels, but it seems to be like the pounding of walking and treadmill, whether that's like overground, but also treadmill.
I'm wondering if like I don't have I personally I don't use the treadmill a whole lot in my sessions. Mm-hmm. I use like a new step or I use a bike because I can crank resistance up on it. What I'll say though is potentially I'm wondering if she would actually benefit from like marching in place, like heavy marching in place though. Because I'm wondering too if it's the treadmill speed, because you know, like there's that weird, it's like that 3.3 to 3.5 miles per hour on a treadmill. It starts to make that weird like hum and it could start to scare people, but that the tread actually kicks up a lot more than it seems like it should. So I'm wondering if that's also playing a little bit into that aspect when she's on the treadmill. So I'm wondering if you can, like, if she could do like heavy impact in place and then heavy impact over ground, or like even be on a trampoline and like bounce and jump and stuff like that too, if that actually might work. I haven't necessarily specifically experienced that directly to that severity though. I have experienced it to an extent where with like, especially with like more so fight or flight with the like burpees that I do or like mountain climbers were like, oh crap, you know, like you want me to do what? And then they kind of do a couple and they're all like get a little lightheaded that way. But I'm wondering if like those are some alternatives that might work for that patient or those patients then.
Yeah, Yeah, your comment earlier about, decreasing the autonomic dysfunction, like cue that in. I thought,
Yeah.
ask that.
That is a big thing too. And I think that's like the one thing that goes unnoticed or goes unchecked a lot for like this population at times with the exercises that are like, oh, they're just like weak and they're deconditioned, but like also what is that deconditioning and the effects of the tumor and the altered hormone levels have on that like actual autonomic function, and whether can they vary, can they like adapt to the intensity too? But sometimes they can't, and we got to really figure out how we can get them to adapt appropriately.
Yep. Thanks, Andrew.
Yep.
Andrew, I'm curious as well. You talked about sometimes use 5 rep max as more just an assessment of progress over time. Do you have specific outcome measures that you like to use at baseline for the different modes of exercise specifically, like to track that progress?
Yeah, so I do. I have like my cluster. So I do like a rep max testing, maybe session 2 or 3, normally with like leg press, a seated row, and maybe like a lat pull down or press, depending on what their range of motion and posture looks like. And then I'll use the Fullerton for my balance. And then I'll either use like the 6-minute walk test or the UNCCRI treadmill test. I don't use the UNCCRI treadmill test a whole lot because I don't have a lot of patients that are necessarily appropriate for it most times, which is unfortunate. But I will try and use that when I can. And that's just like it's a graded test. It's much lower going. It's slower going than like a modified Bruce protocol. It doesn't ramp nearly as fast. But yeah, it works pretty well that way for them. But I do I get the 6-minute walk, and I normally will do like a 5 times sit to stand as well too.
Okay, so you use pretty standardized ones for majority of patients?
Yeah, I don't use anything fancy. But I normally will do like at least 2 of the 3 on the first session, and then I'll get like their 6-minute walk test the next session and start to familiarize them with the machines, and then the third session I'll test them.
Got it. Thank you. Any other questions for Andrew?
And then like here, I'll share my screen because I was able to find the thing though. So this is from a different PowerPoint. Sorry, I'm struggling with this thing, but I blew it up. So there we go. So this is the UNCCRI treadmill test. So like you can see, the speed ramps very slow, and it's a 1-minute stage each time. In the grade also is extremely slow as well too. So normally you'd get into here and grades already pretty high in a modified Bruce anyways, and the speed would be like way above 3.3. So it does ramp slow, and there is correlate values for VO2 max as well. So you could like say, oh, they got the sixth stage and they finished it, but they couldn't get in and finish the 7th. There is a table that will tell you what their VO2 max is as well.
Okay, that's great.
Yeah, and what I'll do is like I'll only do baseline BP before we start it, and then I'll just take it final. I won't take it throughout if I'm by myself, because it's too much to handle between like changing the stages appropriately on time and then checking heart rate, RPE, and SpO2 as well. So.
Yeah. Thank you.
Yeah.
I've never heard of that. All right. Well, if there are no other questions, Andrew did share his email in the chat very generously. So feel free to reach out to him as well if you think of some in the coming days. And then, like I said, the recording and presentation will be posted within the coming week online as well. But I just want to say thank you one last time. We really appreciate you contributing all of this knowledge to each of us. And I hope that everyone took something out of this tonight. So thanks for joining us.
Awesome. Thank you, guys.